Good afternoon, everybody, and thank you for coming. We are presenting a Hospice 101 education, really strictly for healthcare professionals. This is a collaborative effort between St. Croix Hospice, Gunderson Hospice, and Mayo Hospice, and I think individually we can each introduce ourselves and our role. This is very informal. We do have a presentation. There is time at the end for questions, so please let us know if you have questions as time moves on or at the end of the program. There are handouts on the reception desk as you leave if you are interested. Some handouts that highlight the difference between hospice and palliative care. Our business cards are also up there if you have questions after the event as well. And a few facts and figures on hospice currently and its utilization. So I'll start. My name is Dana Bistadu. I'm a care transition coordinator for St. Croix Hospice. Sorry. Welcome. Come on in. We're just introducing ourselves. You haven't missed a whole lot. All right. So my role as a care transition coordinator is to have that first conversation with patients and their families who are considering enrolling in our hospice services or have decided to proceed with enrollment. So having those critical conversations with patients and their families, helping them understand the hospice benefit. I also facilitate and I'm kind of the liaison between long-term care facilities, both Gunderson and Mayo systems, when they are referring patients to our service as well. So maintaining that communication between facilities, other healthcare professionals, providing education both in those long-term care facilities and within the community. Kathy.
I'm Kathy Beaver. I'm the Quality Assurance Coordinator here at Gunderson for Hospice. My job is the fun one. I get to make sure everybody is following the CMS regulations and their documentation is up to snuff. I also do tracer visits with people, which I do promise lunch. So if you go out with me, I will eat lunch with you and I will buy, so that's okay. I've been in hospice since the mid-'80s when we used to carry drugs. We carry morphine and carry the drugs in our car to take to our patients. So I'm not going to say I'm old, but I've seen a lot of changes. Mm-hmm. And the changes recently, even though CMS is coming down a lot harder on everyone, it's probably well-deserved for the most part. Mm-hmm. So sit back. I'm hoping everybody will learn something from this. And if you have any questions, let us know. Mm-hmm.
And I'm Emily McCabe. I am with Mayo Hospice, and I am the hospital and hospice community liaison. So part of my work is in hospice and the other part is in care management, where I am doing liaison work between the hospital discharge process and our local nursing homes. And then with hospice, I do community info visits within people's homes. I do info visits in the hospital. I do hospice education facilities or offer it. And then I do some auditing and other behind the scenes as needed things. I've been with hospice for almost 2 years and as a nurse at Mayo for almost 10.
Nice. All right. So we have a few objectives that we want to cover today. The general idea of what hospice is, the benefits, the difference between hospice and palliative care. We'll talk a lot about eligibility, and that has had some changes, and Kathy will highlight some of those. And then a lot of the hospice myths that we hear as well from not only healthcare professionals, but our patients and their families. So what is hospice? Really the goal of hospice is to provide a quality of life for those with a terminal diagnosis. It is caring for someone with a life expectancy of 6 months or less. Obviously that can continue as the patient remains eligible. But really we're supporting that physical, social, emotional, and spiritual needs of the person and their family. We really truly serve their family and their loved ones just as much as we serve the patient. We are not there to hasten nor postpone death. That is often a fear of the patient. And we're primarily there to educate the caregiver on providing 24/7 care for that patient. So educating the family and loved ones who are providing care in the home, educating facility staff if the patient is residing in a long-term care facility. It is a benefit covered under Medicare, Medicaid, and most private insurance. I would tell you 100% of the families that I have sat with are not aware that it does not have any financial impact on them. They may have been told, they may have just lost it in translation, but I have had patients tell me that is one reason I haven't called you yet. We have all of these medical bills. We didn't want another one. So letting them know that the equipment, supplies, medications related to the diagnosis, they don't have a price tag. So let us put some of those tools into place. And we provide care to a patient wherever they call home. The hospice care team is definitely that interdisciplinary approach, which is most valuable. Everybody really does have a unique role. As far as the hospice physicians, they are overseeing a patient's plan of care, communicating with the patient's primary care physician. We do not expect a patient to give up their primary care physician. They're very well informed and very much a part of the hospice journey for their patient. That is often a fear as well, as patients have really established a trusting relationship with their physician. They don't want to give that up, so they are often pleased to hear that they don't have to. Obviously, the RNs are there to coordinate clinical care, educate patients and their families and other caregivers, adding interventions. Social workers are a very valuable part of the team. They're helping with community resources, bringing additional support into the home if needed. Do they need services such as Meals on Wheels, a lifeline? Do they have questions regarding advanced directives, deeds to the home, deeds to a vehicle, funeral home planning? A lot of things that aren't always thought about, even in the last days by a family, is what the social worker can kind of prompt and have those conversations with. Dietitians are able to help with nutrition, sometimes in complex cases. Music therapists, massage therapists, we all know their benefit. And PT, OT, and speech are helping to maintain functional abilities, strategies for pain control. They are a huge part of the team when needed. And chaplains and bereavement counselors are also very valuable. A lot of times I'll have patients kind of wrinkle up their nose and say, I don't really need a chaplain. But I do encourage them to at least accept a few of their visits and understand that religion, spirituality, meditation, whatever it might mean for each patient is different. It's not coming in boasting religious views at all. Our chaplain says it best. She says she's multi-denominational. So for some patients, that means playing Elvis. For some, that means saying the rosary with them. So everything can be a little bit different. I just went backwards. All right, hospice volunteers. You may or may not know that Medicare requires 5% of our total patient care hours to be provided by volunteers. That is always been a stipulation. It did ease up during the pandemic. We did lose all of our volunteers during the pandemic, and we're building those back up again. But those volunteers can provide companionship, vigil visits, clerical support, pet therapy, running errands, a little bit of light meal prep at home, allows the caregiver to step away when that volunteer is there. And sometimes it's a neutral ear for the patient to have a conversation with about topics they don't necessarily want to talk to their family about. So that is one rule and regulation under Medicare. Oh, there are 4 levels of hospice. I'm going to briefly touch on the definition of all 4. Level 1 is routine care. It is the most commonly used. You can see the care team listed there. It is providing those tools such as medications, medical equipment, supplies related to the terminal diagnosis, putting those tools into place and providing care wherever a patient calls home. Level 2, continuous care. This is meant for short term. These are during periods of crisis when a patient's symptoms are not managed. This level of hospice care cannot be provided in skilled nursing, hospital, or inpatient care facility. The word continuous can have some difficulties to understand what that means. It does not need to be continuous care in a 24-hour period. However, it does have to have a total of 8 hours or more within that 24-hour period. So it's a nurse or nurse aide at the patient's bedside for at least 8 hours in a 24-hour period, really trying to manage those symptoms and during periods of pain crisis, severe nausea, vomiting are examples, severe shortness of breath, anxiety, and sometimes it's just simply a breakdown of the primary caregiver support. So something happened to the caregiver, and now we need help because there's no one providing care and supervision. Let's see if I get this right. General inpatient care is level 3. This is for patients with short-term symptoms that are so severe that they cannot get their adequate treatment at home. This is, the expectation is that nurses are available at bedside 24/7. And this is for really rapid assessment, medication changes to try to get those symptoms under control. Inpatient facilities, examples of where a person can receive this care, of course, a freestanding facility owned and operated by a hospice company, inpatient hospice unit within the hospital, or hospice unit in a skilled nursing facility. And respite care is the final level of hospice. This is providing that brief break and respite for the primary caregiver and their family. Maybe the primary caregiver is stressed, exhausted. Maybe there's other extenuating circumstances. We've had caregivers have their own medical crises, and then all of a sudden we need to put into place a plan. Respite care is temporarily being admitted to an inpatient environment for up to 5 days. And once that 5-day period is complete, the patient does return and discharge back to where they call home. So it is a 5-day break. Oftentimes what I've observed is it's being used because caregivers are exhausted and they just need a break. Maybe there's a family event that they need to attend to and they want to be able to be part of that. So oftentimes if a patient doesn't meet criteria for the continuous care or inpatient care, respite care can be an option. How to pay for hospice. I mentioned briefly earlier that it is 100% covered under Medicare, Medicaid, most private insurance companies. Again, that's covering the medications, supplies, and equipment related to their comfort and related to the terminal diagnosis. Again, that is always an eye-opener for families. You can see their shoulders relaxing when they hear that the support that hospice brings doesn't have a cost. So that's just a huge relief for them. If there's ever a situation where an item had a cost, that is definitely discussed before it's put into the plan of care. So hospice also covers room and board under inpatient and respite care. So for those respite days of 5 days, hospice is paying for that room and board. Private pay is definitely an option. We've all talked about how we do serve the Amish population and other cultures that do have to utilize the private pay option. And most hospitals and hospice programs have a charity program that can assist with financial assistance also. So really no one is really turned away if they can't pay. There will be a plan put into place. All right. Are you laughing at me? I'll find the right button pretty soon.
All right, so the benefits of hospice. First up is physical care. So the hospice team are experts in pain and symptom management. That is the primary goal when somebody comes onto hospice, is to have that pain managed and for them to be comfortable. Hospice provides all medication, supplies, and equipment that is related to their terminal illness. So hospice does not always cover all of their medications, but we would cover things that are related to the terminal diagnosis, and that would be communicated to the patient and caregivers, what's going to be covered and what's going to, process through their insurance the way it has been before. We have registered nurses on call 24/7. So if that's something that's a really big motivator for people to come on to hospice, is knowing that there's somebody that they can call in the middle of the night or on a weekend or on a holiday, when normally they would either wait until the clinic is open or they would come into the emergency department. They can just call a nurse and speak to somebody who can help them either over the phone or come and do in-person visits 24/7. And then having access to a dietitian to help with end-of-life nutrition needs and education when it comes to different types of diets and the process of how feeding and things like that go at the end of life. Psychosocial care, we have assistance with coordination of care from our social workers, and the grief and bereavement process for patients' families or facility staff after somebody passes. Spiritual care, non-denominational or multi-denominational chaplains that can help with spiritual support and reflection. Like Dana said, it can be as religious or non-religious as people want or need. Sometimes we have people that want to be prayed with, and other times people want to talk about their spirituality or, what comes next. A lot of times people have just different in-depth conversations with those chaplains than they would have with the nurse or the social worker. Some of those spiritual conversations can be really important. Alternative therapies, so music therapy, massage therapy. Different hospice agencies offer different options for alternative therapies. A lot of times the music therapy is really nice, not just for people in their homes, but in facilities. A lot of times it can not just help the patient that they're there to visit, but everybody else that's in the vicinity of that music therapist when they're playing at those facilities. The volunteer support, like Dana talked about, that companionship and being there for vigil. A lot of times our in-home patients utilize the volunteers to be eyes on the patient when a caregiver or family member has to be out of the home, whether they're going to their own appointments or if they are going, out to do yard work and they don't want to leave their family member in the house without eyes on them. We can utilize volunteers for things like that. Volunteers cannot do hands-on things with patients, so they can't help them to the bathroom or do bathing or anything like that, but they can be there to do puzzles, games, keep an eye on them, things like that. And then grief and bereavement. People can be a part of bereavement services for 13 months after someone passes away. So that's for the patient's family, friends, and facility staff if they were living at a facility. That can be as much or as little as somebody wants to be involved with bereavement. So it can start with just a phone call from the bereavement counselor. She sends out mailings and has phone calls, groups, one-on-one conversations. So she can be there for people as much as they want her to be there. Almost lost that slide. So the benefits of hospice. So access to that nurse 24/7 is probably the biggest one that people really look for when they're trying to decide if they want to go on hospice. That can help with improved pain control, as it's a nurse that they're talking to, so they're able to talk through what the patient's been given, what the options are for PRNs, if they're able to adjust dosage, during those after hours times. Reduce physical and emotional distress, especially for caregivers. Just knowing that they have somebody that they can call anytime really makes them feel a lot more comfortable keeping their family member at home. And same with in facilities, them knowing that they can call us and we have a staff member that's awake and going to be answering the phone at any time. And then reduced prolonged grief and other emotional distress. It's just having that access and knowing that there's somebody to call. Hospice prevents hospitalizations and ED visits. Of course, primarily with hospice, we want to eliminate those hospitalizations and ED visits. We know there are some circumstances where things happen, but we primarily want to keep people in wherever they call home. So that's why the staff that is part of their hospice team will come and see them wherever they live, and do whatever we can to make them comfortable and treat their symptoms without them having to come into the emergency department. Lower medical costs, like Dana was talking about. We don't send bills to anybody who is on hospice unless they're private pay, of course. But if it's covered by Medicare or Medicaid, private insurance, they are not going to have to pay directly for any of their hospice care. And patients live an average of 29 days longer when they are on hospice than when they are not. We send regular updates to the primary care physician, facility staff, and family. That's a big part of hospice, is being in constant communication with whoever is caring for that patient during the time that hospice is not there, and any family that is involved in their care, whether they're at a facility and maybe their family lives out of state or across the country. Just making sure that everybody's on the same page, and then whoever they designate as their physician, keeping those people in the loop so everybody's on the same page. And family reporting greater satisfaction. Families usually at the end of, or at any point when someone's on hospice, they are just really grateful for all of the added support, all the conversations, all the honesty that hospice can give them. We hear over and over again, even just in the information visits, like, I didn't realize how much you can do or how much you can help. I know you can't be there 24/7, but just knowing that there's somebody to call, someone can come here, you can make sure that my family member or myself is happy and comfortable, is just really comforting for them. And then for patients in facilities, it would be any hospice patients that are residing in a skilled nursing facility or assisted living facility when they're on hospice. The facility staff would remain that person's primary caregiver. So hospice would be added support. So of course we can't provide that 24/7 care. So the facility staff would still be the ones primarily taking care of that patient, and hospice would be there as a support to them. Like I said, communication is key, just keeping everybody in the same loop, on the same page, making sure we all have the same goal of keeping that patient comfortable, and carrying out their wishes. Like them and their family are choosing to be on hospice, and just making sure that we're carrying out their wishes and keeping them comfortable. Hospice complements the care provided by facility staff, so we are not there to get in the way or try to, do anybody's work or, do things better or differently or anything like that. We want to be a team to help take care of the patients that are in facilities, and do whatever we can to work together. So promoting collaboration, supporting the patients, supporting the families, just having those eyes on that patient when, we know that facilities are, tightly staffed, and we want to be able to be there for our patients and have eyes on them and maybe see things that are, overlooked, or, just have more eyes on the patients whenever we can, and especially when hospice is something that they want. So that would fall under that coordination of care, as well as keeping everybody in the same loop. So the value that's added to facility staff, having that triage available 24/7. Usually facility staff have people that they can call, in off hours, people that are on call. Just knowing that the hospice nurse is awake and there to answer the phone calls is reassuring. Preventing those ER visits, it's a lot of work, I know, to get an ambulance out there and get those patients off to the hospital, and then if they send them right back, then having to get them back, us being able to come in and manage those symptoms and keep those patients in their home or their facility room is very important. Having nurses on site for critical time, so if somebody falls, notifying hospice right away, we can come out and assist. We want to come and check their vitals and check them over, if they have injuries, things like that. And then also at time of death, hospice comes, we can do all of the paperwork, calling the funeral home, all of that. Sometimes we can offer personal care services like our home health or bath aides. That's just kind of dependent on the agency and their aid availability. We primarily use them in the in-home setting, but we can sometimes offer them to facilities depending on, case-by-case basis. And we are not there to duplicate efforts or services. We really want to work together to try and lighten the load for facility staff whenever we can, and just not, getting in the way and doing things that are unnecessary, but trying to support the patient and support the facility. And then also offering ongoing hospice education to patients, family, and facility staff. So all of our hospice agencies can offer hospice education to facilities, talking about hospice philosophy and the good that hospice can do for your facility.
Okay, my turn. How do we get these services? How does your patient qualify? You've got a patient who just not sure. I want to go over with you how they qualify, how you can look at what the patient, what's going on in their life, what's going on in their symptoms. Not that you have to qualify them. This is just to make it aware of you see patients and you think maybe that might work for them. First thing is you want to make a verification that there is a terminal prognosis, that they have terminal prognosis of a 6-month or less expected death. That does not mean that they have to die in 6 months. That only means that if the disease progresses as it has textbook, that they probably have a 6-month life expectancy. Each patient, when they sign in, they're reevaluated at 90 days, second 90 days, and at 60 days. Medicare requires that they have a decline, or we can show a decline, and they're still requiring our services. Private insurances also pretty much go by the Medicare standard. So even though they have private insurance, we're going to treat them the same way. The CMS standards are for everyone. They have to want hospice. They have to have decided that there's no curative options. They've run through every curative option. They're no longer strong enough for any further treatments, or they've just been diagnosed and they decide, nope, I'm done. I've had a long life. I don't want any more. That's perfectly fine too. You want to at least review if you decide you see a patient and you think, well, hospice might be a good idea. They've got all these services available. They probably have a terminal diagnosis. Speak with the attending. Talk with them and see what they feel like. Has this ever been discussed with the patient? You do not want to be the first person walking into that room going, hey, I've got a deal for you, hospice. That word doesn't have a real good connotation with a lot of people. So you really want to see what they've been told, see what they know about their diagnosis, ask the attending and the nurses and whoever, just so that you aren't the first one walking in and shocking them with that. You also want to make sure that they have a primary caregiver, someone who can take care of them. Hospice does not move in with them and take over care. If they don't have a primary caregiver, what's the plan? Because we know they're going to need more care. They know that they're going to need somebody with them. At this point, we should have already, or at least talked about having a plan for them, even if they don't go into hospice, that we can get a plan in place. Now, when you call us, and that's once you've decided that yes, hospice might be a good idea, they want more information, that's fine. When you call the intake office, the nurses there are going to ask you some questions. So if you have the patient's information available, if you don't have it, we can actually find it. We can talk to the attending. We can do all that for you, but it makes it a little bit easier if we can get that information for you. we're gonna assess their eligibility, whether they do have a terminal diagnosis or not, or are they far enough along on their terminal diagnosis that they would qualify for 6 months or less. A big one with that is Alzheimer's. We know they can decline, and they can decline very slowly. Some of the people that come in with an Alzheimer's diagnosis aren't ready for hospice yet. They don't qualify. And that would be our job, to go through and make an evaluation and talk to you about it. And what are your options if hospice is not an option at this point? We also go in, and Dana goes in and does this and looks around the environment. Is it safe to bring the patient home? Is the house, are you able to, I know we've had some houses that the electrical boxes won't handle the oxygen concentrator, or they don't have heat or air, or their floor is just about gone and they're gonna need or their steps are falling apart, or it's doing absolutely wonderful, but they have 10 steps to get up into their house. So there's a lot of things like that when we do the initial evaluation. Not only do we look at them, but we look at the environment, and is it gonna be feasible that they do that? And the last one is the primary caregiver going to be able to meet the needs? Someone who's 98 years old, who has a 92-year-old wife whose plan is to take care of him till the end. She's just as frail and has as many medical problems as he does. Okay, we'll get the children. The children are in their 80s with their own health problems. Move down to the grandchildren. Maybe they don't live in the area. So those are the things you want to consider. That isn't a stopping point for us. We can find caregivers. We can make a plan with hired help. We can help people who've been piecemealed together, worry about assisted living. There's a lot of different options. So don't think that just because the caregiver may not be able to do it, we'll look into it and we'll see what options we can do. We never want to keep a person from end-of-life care in their home if we can possibly help it, if we can possibly do it. Here's some indicators for hospice. Most people think cancer, heart disease, COPD. There are a lot of other diagnoses that are now covered for Medicare for the indicators. Kidney disease, renal failure, any type of pulmonary disease, from fibrosis to cancer to COPD, malnutrition, those frail people. Now, it used to be that you had to have one of these diagnoses and that's what would cover you. Now, the new regulations, you can have one of these diagnoses, but you're not really that close to the 6 months, but you have 3 other things. You're a diabetic, you're hypertensive, you have COPD. You've got a lot of comorbidities that add into that. So that's all taken into account. It still might not get you a hospice admission at that point, but don't think that just because they don't have one of these indicators that the patient can't be in hospice. So it's an overall picture of everything that's going on. That would be indicated by the medical provider, and our medical director would look at that case and make an evaluation from that point on. So it's not something you have to decide on, but if you feel that this might be a benefit, please talk to your providers and see what you'd like to do. Now, some actual primary indicators: increased hospitalizations or frequent visits to the ER, frequently calling 911, that we could probably negate with a little more care and a little more support in there and try and get their symptoms under control. Progressive weight loss without trying. It's an unintended weight loss. Not that they can't afford food, but they're not eating, they're not doing anything. Changes in comprehension. We all know that happens as they get older, but are there other things going on with the comprehension that we need to look into? Falls with injury. That's a big one, and I think we all know that's a pretty bad sign when they're having a lot more falls with injury, that need to look into that. Decrease in appetite, increase in the number of infections or wounds that they're having. Even if they're being treated and we're able to heal them to a point, just the sheer fact that they're having those is another sign. Incontinence, edema, weakness, shortness of breath, anything that has to do with an ADL also. If they're declining in their ADLs, it's time to start looking and see, is there an underlying problem, because they won't go to the doctor. And maybe they do have a cancer or another heart disease, and they don't want to deal with it. Now, these are the hospice cases by primary diagnosis. Never mind, we switched slides around, sorry. Um, if you look, one of the highest ones is Alzheimer's. And number one is because the cases being diagnosed are so much higher now that it's getting much more fluid in the community. It's there a lot more. But we're also finding that patients, we can offer them a lot with Alzheimer's towards the end of life, both the families and the patients, to make them comfortable, to give them some quality of life as they're heading in. Heart failure, cancer is our second one, which is no surprise because that was what was initially, hospice was for cancer. That was the only diagnosis that people recognized as being hospice. "75% end up in the ER in the last 6 months of life, and that's being conservative. When you start counting that there's maybe 2 or 3 ER visits that they're coming in for. Late stage illness frequently go there because they have nowhere else to go. They're having pain, they're having trouble breathing, they want relief right away, and they have no other options. Hospice is a way of giving them an option of calling a nurse, getting medications in the home, getting a plan in place. So it isn't nearly as scary, and they're not going to the ER because they're scared and they don't know what to do. We've taught them what to do. Having the hospice conversation with someone, with a family, won't necessarily be something that you're the first one going to be doing. It may be. You walk in that room and the family says, okay, we've heard about hospice. My neighbor is on it. What's that all about? And you kind of go, give me a minute. And then you can give some general information. You can say, I can get someone who can talk to you about that if you'd like. What are your concerns? What are you thinking about? Why did you ask me that now? Do they have some concern that you haven't realized that's going on with the patient? That the patient is either hidden from you very well, or you're just not sure what's going on. Palliative care might be an option if you're still looking for curative measures, but have an end-of-life prognosis of maybe several years. Maybe your disease process you know is heading that way. It's a life-limiting illness, but you're not there right now. Palliative is also another way of looking into it. We're not going to talk about palliative today, but if you have any questions, certainly feel free to ask and we can answer them. Review what's going on. What do they expect? What is their perception of what's going on? What are the concerns? I like to go in, and I was always very big on going in, going, here's the hospice spiel, and I'll tell you all about it. And I never answered their question of why they asked me to come in. And I think we have to stop and think about that as to, what prompted this right now, if they're asking you. Learning the signs and symptoms of the disease processes and what you do so that you know this might be coming up. And when and how to have that hospice conversation in conjunction with the attending physician. Explain to them that the patient's asked, can I go talk with them, or can I ask someone? And he may already be saying, yeah, that's a good idea, or no, I don't think this is the right time. And at that point, you just have to let the patient know that. But that's real rare, incredibly rare. Median length of stay of hospice is 17 days, and I've had them as short as 20 minutes, and I've had them as long as 2 years. As long as you can show a progression. And the 20-minute stay was a patient who was Muslim, that they did not want to be, she did not want to die in the facility. She had to be in a certain sheet, in a certain bed. She had to have family members and prayers, these prayers around her. We got her home and got her into the bed. 20 minutes, literally the family signed it, went into the room, and I just stood and waited until she had passed. But they had all these rituals that had to be done, and the family was just grateful that they could do that. That was something that was really important to her. So it sounds like it's really a rough time. Why did we do that? Why didn't we just leave her in the hospital? That wasn't an option for us. We had volunteer ambulance drivers come in because they didn't have an ambulance. They were all in service. we had volunteers come in to take her home. So length of stay, 17 days, that's a good thing. We'd like to get them in earlier. The earlier you get them in, the more that you can develop a relationship, get the meds in place, get the plan in place. But 17 is average. That number should be much higher. 50% of residents across are eligible for hospice, but they don't use it. One of the big reasons why is they don't know about it. They don't know what's offered. They don't know that it's here. They don't know the price. They don't know what to encompass. You hear hospice, they're going to kill me. I've had hospice patients walk in to do the thing and they're, okay, when is it time? What do you mean, when is it time? Well, when are you going to give me? Because I'm going to die. When are you going to give me my stuff? No. So that's, education is a big deal with everybody. And the more we educate you guys, the healthcare providers, so that you can dispel some of those myths that come through, we might be able to raise that number. Because we know we have the staff and we have the capability of doing it. We just need the patience.
All right. I wanted to briefly discuss concurrent care for our service-connected veterans. I do partner with both the Toma VA and the La Crosse VA and provide support to their veterans that are referred to our hospice services. I've learned a lot. The VA is a very complex system. They do have a lot of additional supports that can be put into the home. But back in 2006, they did kind of review the percentage of veterans who were enrolling in hospice. And in their words, who was making that awful decision to enroll in hospice? Only 5% of their veterans were receiving hospice care. So in 2012, they began allowing disease-directed therapy in conjunction with hospice. So while enrolled in hospice, the veterans can get some of these treatment options that you can see. They call it concurrent care, and it has significantly lowered the costs due to the less of the need for the crisis emergency visits, the hospitalizations, the ICU care. They are able to have home health nurses come in, palliative chemo, radiation, IVs, transfusions, and different things that are funded by the VA pay. So the VA actually funds these treatments while they're enrolled in hospice services. All right, our last few topics are the myths. Kathy's going to start us off with those.
Hospice means giving up. No. Hospice means changing your focus to quality of life instead of the time of your life, how much time you have left. You have quality. That includes the loved ones, that includes family around. They have a higher quality of life, fewer hospitalizations, and lower costs overall when people are in hospice. It's costing Medicare. We're offering all these services. All of a sudden, isn't Medicare being billed more? Doesn't it cost more to do all this? Have a nurse and medications, everything right there? It doesn't. We save money to Medicare by preventing those ER admissions, by preventing the unnecessary hospitalizations or treatments. We all know the patients who have blood transfusions every day that aren't helping anymore. If that's what need to be, but oftentimes it's because they don't know anything else. The doctor says we need to do this, and that's what we're going to do, but we give them an option. So we do save money in the treatments and everything that's going on that you're used to paying for in a regular medical system with that level of care. This is a biggie. This is always a sticking point with people. Patient has to be a DNR to be in hospice. No, they don't. If there are agencies that only accept DNR patients, that's fine. That's an agency policy. That is not a CMS requirement. It is not a rule. So there are other agencies. If you find an agency that does require you to be a DNR and the family does not want that, then you can find another agency, talk to another agency. DNR is do not resuscitate, which means they want a CPR. They want to be on a ventilator. They want all those treatments. when you ask them why, because I want to get better. And I've seen it on television that when they do that, they wake up and they're fine. You have to explain to them that that's probably not going to happen with their disease process. And the fact that going through that is very painful for them and for the family to see all this. And DNR, sometimes they say, but if I do that, no one will ever take care of me. They'll just forget me and that'll be it. And you explain to them that no, that just means that if your heart stops, we're not going to try and restart it, but we're going to make you comfortable up to that point. And you can go out in your backyard if you want up until the day you die. If you want to, we'll take you out in a wheelchair or your bed, or we'll make it so that you're okay and that that's not really a problem or concern. I missed one.
That's okay.
Once enrolled, a patient cannot disenroll from hospice. That is not true. If somebody's health either improves or they plateau with their symptoms, so they're no longer having that decline, so they would not requalify for hospice. They can be discharged from hospice. People can also decide themselves that they want to disenroll from hospice. So once somebody signs up, they're not locked in and have to stay with us forever. There's options, including people ask like, well, what if I move? What if I move from my home to my son's home, which is hours away? You can stay enrolled in hospice and we would just transition to that location. Which comes to the next one. Once enrolled, a patient cannot travel. Patients, of course, can travel. Anything that is a day trip, we, don't expect to have to do travel contracts or things like that if somebody's going to be, in the area. But if somebody is traveling overnight or for a longer stay, we will connect with a hospice agency that services the area that they're going to, so they would still be covered by a hospice when they are not within our service area. And you must use a hospice agency recommended by your healthcare organization. It is required that patients are given the option to choose their hospice agency. If somebody calls one of our hospice agencies specifically and asks us about hospice or to enroll in hospice, that is their way of already making that choice. In the hospital setting, if somebody is given the option or wanting to enroll with hospice, then a discharge planning type person should be giving them all their hospice agency choices based on where they live or where their location is going to be. So they have the choice to choose whoever they want. And if somebody does enroll with a hospice, they have the option to choose a different hospice if for some reason they feel that they need to. That is always an option.
All hospices are the same. We are all under the same CMS rules and regulations, but each hospice does have, they may differ in their programs, services, and policies. So it is important to have that knowledge as you are working with all hospice agencies to really understand what those are. You must give up your primary physician. I spoke about this earlier, but this is heard a lot by patients. So please just help to reiterate this message that no, you don't give up your primary physician. It's very much a partnership. And all medical decisions must be made before enrolling. Again, that is a myth. Those decisions and goals of care are constantly discussed and can be adjusted anytime throughout the hospice journey. It is a very hard shift in focus to comfort care for a patient who has maybe been under a lot of cancer treatments, and all of a sudden they're worried about the labs and the scans and those numbers that they've been focusing on for so long, and then shifting to comfort care where there are no longer numbers to monitor. So that is a very hard shift, but those goals can always be adjusted. If there's a new cancer treatment that comes out or a trial drug and they want to do that, they just disenroll from our service and they can go and seek that treatment. So, and finally, who can make a referral? Anyone. an in-home private caregiver, a minister. Obviously, you guys as healthcare professionals, families can self-refer. Anyone can really reach out and ask for a consultation. That really concludes our presentation. Are there any questions from anyone? Yes.
Any considerations for a pediatric referral, or do they follow the same guidelines?
Sure. The question is pediatric hospice referrals. For St. Croix Hospice, we serve people that are 18 or older. Maybe I can ask one
We
of
do
you two.
newborn and up, we do pediatrics.
Gunderson does newborn and
Us
up.
as well.
And so does Mayo. So personally, maybe I'm thankful that we don't do pediatrics. Other questions? Yes.
So the Medicare rule about 5% volunteerism, is that across the board, or is that for individuals who are receiving services through a payer source of Medicare?
The question is the volunteer expectation that 5% of total patient hours are provided by volunteers.
That is across the board, that's regardless of how it's being paid, that's for the agency itself.
Yeah, so it's not per patient 5%, it's just a
Right.
total hospice hours.
Yes.
Correct. Through volunteerism. Yep. Yes.
At least 5%, at most 5%, or exactly 5%?
5% is the minimum. So more than 5% is great. 5% is just the lowest.
Yep. Other thoughts or questions? Well, we'll be around for questions if you wanted to ask us anything in person or available for autographs also. So
Don't forget to grab some handouts and business cards on your way out.
thank you all for coming.
Thank you.
Thank you.